Okay, good afternoon, everyone. If it's all right, we'll make a start. There'll be more people joining us as we go through. Warm welcome to everyone, and thank you to everyone who's attending today. My name's Anthony Gibson. I'm the National Clinical Lead for the Respiratory Network as part of NHS Performance and Improvement. We've been running this series of Respiratory Matters webinars as a way for colleagues across all parts of the health system to get together, share knowledge, to understand what is current best practice and where things are changing. Well, I welcome you to this webinar in our series. Just a few housekeeping rules if we can. If we can keep microphones muted and cameras off through the session. We are recording the webinar today, and it'll be shared on the sort of Respiratory Matters channel and the network website for those people who want to revisit it, or if you want to share it with colleagues after having taken part today, you feel it will benefit colleagues, please feel free to share it. We will provide certificates of attendance for anyone who wants those for their CPD diaries as well. So today's session is around asthma care in children, concentrating around transforming care in Wales, but also some around the new clinical guidelines. We're very lucky that Professor Julian Forton, who is our paediatric lead within the network, has agreed to pass on his expertise today. I'm sure many of you will know Julian, but he's a consultant in paediatric respiratory medicine and cystic fibrosis at the Children's Hospitals for Wales in Cardiff. He's the undergraduate education lead for child health at Cardiff University School of Medicine, and his presentation today is going to cover some of the audit findings for Wales, benchmarked against England, the infrastructure in place to support asthma care, including what digital tools we have available and education platforms, and then essentially going to run through the new All Wales medicine guidelines for asthma care in Wales, which is based on the updated NICE guidance. So I'm going to hand over to the person who's interesting today, Julian, and thanks very much for giving up your time to give this talk as well.
Anthony, thank you very much. Can you hear me okay?
Yeah, really well, thanks. And we can see your slides. Great.
You can see the slides as well. Fantastic. Good afternoon, everybody, and thank you very much for coming today. Paediatric asthma, a big issue for us in every healthcare location. It crosses primary care, secondary care, and tertiary care. And I think today I'd like to talk a little bit about how we're doing, what infrastructure we've got so that people can benchmark their own care against what's available. Talk about our existing All Wales asthma diagnosis and asthma management protocols, and then talk about the 2024 NICE guidelines and how they affect children. So I'll pass over these. I'm part of the National Strategic Clinical Network for Respiratory Conditions. Here are all the people that have helped with this presentation today, and part of the team working for all elements of improvement in respiratory care. I put this up because we have a website, and all of our pathways and guidelines that I'm going to show you are available on this website. So going back a long time, so that we get the context of where we are today, the National Asthma Deaths Inquiry in 2013 looked at all deaths from asthma in 2012 and identified what made a difference and what was lacking in those patients that died. And from that, they developed a national quality of care set of indicators and a template for standardization of care. And with that, the Royal College of Physicians took on a national audit to help everybody track their services against those national standards. That used to be called NACAP, and it's called NRAP now. And this is a level 1 national audit. And so asthma really has become an NHS regional performance measure. And I'll show you how we're doing compared to England in a moment. just to say that NHS England does have a slight advantage over us in that they have a tariff against good care. They have CQuIN, the best practice tariff, and the CQC. Whereas in Wales, we have less levers to identify quality markers in care, but we do have the NHS Respiratory Network. We have the AWMSG for our guidelines, for rigorous guidelines. And we have a collaborative approach, a common goal theory. We're a smaller country. We have stronger relationships. So what did make a difference when they looked at those national quality standards? Well, for an acute exacerbation, giving steroids within the first hour was important. Patients needed a personal asthma action plan. They needed a structured discharge care bundle to include looking at inhaler technique and addressing smoking. They needed structured secondary care follow-up, an annual structured review in primary care, and appropriate referral thresholds to the specialist. So here is the NRAP audit programme. As you can see, it looks at adult asthma, childhood asthma, pulmonary rehab, and COPD. We'll look at the children now. Just looking at this slide, the dotted line is England and the full line is Wales. And this is where the steroids were given in the first hour. So we're comparable, slightly less good than England on this marker. In green, in the full line is Wales, and again, the dotted line is England. This is the percentage with an inhaler technique checked, and we've consistently outperformed England on this one, and similarly with the percentage of personal asthma action plans distributed, running at about 60% for the last 3 or 4 years. Here we've got the percentage in receipt of a full discharge bundle, and again, in green, we are better than England. And the percentage referred to clinic within 4 weeks, a secondary care follow-up after an exacerbation, slightly less good than England, probably resource limited. And here is the number of patients or percentage of patients sent home with inhaled steroids at discharge, and it's 100% in Wales. So on these metrics, I think we perform equally well, if not slightly better than England. Here we have percentage of patients exposed to secondhand smoke in green, and as you can see, we're at about 30%, whereas England is at about 15%, and we're referring twice as many proportionally to address that tobacco dependency. Here is a snapshot in table form, and I think you can see that for inhaler technique, personal asthma action plans, we're doing very well. So I was a bit surprised to see this on ITV News. Gaps in asthma care led to 1,000 children being admitted to hospital in Wales, says the charity. So I had a quick closer look. This is emergency admissions for children in Wales since 2009 till today. And as you can see, it has been dropping. It dropped profoundly in 2020, 2021 during the COVID epidemic, and has risen back to probably where it should have been if we hadn't had that COVID epidemic. If we look at England, it's similar, and we compare the two, we're very, very similar, and this is proportionate to the environment. So I was quite interested to look at data from England about asthma admissions over the last decade. This is all of England, but looking at different regions, Birmingham, the admission rate is higher, Middlesbrough, higher, Liverpool, higher, Manchester, higher than average in England, probably lower socioeconomic groups there. Here we have West Berkshire and Cambridgeshire and Buckinghamshire and Oxfordshire, all probably higher socio-economic living in these regions, and the admission rate is lower. So I looked at the Wales data as well. Here we do have some variability between health boards, but very interestingly, if you look at this data over the last 12 years or so, for the 5 quintiles for socioeconomic status, you can see that the most deprived quintile is in red and the admission rate is higher, and the order from least to most deprived quintiles show an ever increasing admission rate for asthma. So really, we do have a very important determinant of asthma admissions in socioeconomic status. If we look at Oxfordshire versus Birmingham, which we've already talked about, see how they're doing on the NRAP markers, we can see that the John Radcliffe Hospital, which I worked in and I'm very fond of, is not doing particularly well. 41% and 48% for personal asthma action plans in inhaler technique. Yet Birmingham Children's Hospital are doing extremely well, 93%. So really, this gives us an idea as to how important and how strong an influential factor socioeconomic status is. So hospital admissions rates are largely determined by socioeconomic status. Hospital admission rate, therefore, not really a marker of quality of care. We're comparing apples with pears in a way. But national quality of care indicators will also have an effect. And if I put the line there where the NACAP, NRAP data started, I'll leave it up to you to see whether there's been a significant change in asthma admissions since then. Difficult, I think, to tell, given that we had the COVID epidemic in the middle of it, but we'll see. Right. Let's move on to how to manage asthma in children. In the olden days, it used to be an easy treatment decision. There was one inhaler for prevention, one inhaler for reliever, and one type of spacer. And now there are many practitioners and many choices. And this is a drawing I once designed for my hospital and my health board, looking at how many different opinions somebody coming into hospital with asthma may get if we're not consistent in our approach. And what you end up with is a multitude of different solutions, different spaces, different relievers, different approaches, and complete confusion. There's a disparate evolution of care pathways, different solutions. It's very confusing for the patient, confusing for the staff, impossible to audit, and standards are unknown. This is now called unwarranted variation, and it's something we really need to avoid. So the medical professional really does have a responsibility to collaborate and simplify care. And this is really what we're trying to do with the network and what was done also with the implementation group beforehand. So where to start? We've got 55,000 children with asthma in Wales, only about 1,000 admissions a year. So a lot of the work is in primary care. We can, of course, standardise acute care, which we've done, and we need to think about how to standardise community care. So I want to talk a little bit about the infrastructure now that we have available in Wales. It's fairly sophisticated compared to England, and I want to go through what's available for helping all practitioners, wherever they are, all allied healthcare professionals in managing asthma. So we have a national integrated toolkit. We have national clinical guidelines. We have an asthma app, quality improvement initiatives, and a standards and educational website. So for Paediatric, that's for adults and for children, but for children, we've developed an acute asthma and wheeze personal asthma action plan, and we've managed to establish a generic acute asthma and wheeze acute asthma pathway in every hospital in Wales. We've developed an All Wales asthma diagnosis guideline, which I'm going to spend some time on in this talk, and also an All Wales paediatric asthma management and prescribing line, where we've been very specific in prescribing choices, national prescribing choices, and also referral thresholds, and I'll go through that in detail as well. If we look at the ICST website for education and standards, there are several paediatric elements to the asthma suite there. Examinations, courses, workshops, and videos, lots of excellent talks and education for all allied health professionals. So please use this platform if you can. It's available to everybody. And now I'd like to talk a little bit about the asthma app, which exists actually for pediatric asthma, adult asthma, and COPD. It was initially developed for children and was extrapolated and templated to those other diseases. The key features of the app is that it becomes a digital personal asthma action plan. There's an escalation plan or sick day plan. There is the opportunity to document your annual review at the GP and to modify the asthma action plan each time. But the most innovative thing, I think, is the monthly asthma checker, which is a set of 10 questions designed to which the patient is sent out on their app to answer. And these are questions that you would be familiar with. The sort of questions you might ask in clinic. How much salbutamol are you using? Have you been to A&E? Have you been to the assessment unit? Have you had steroids? Are you coughing at night? It includes the RCP3 questions. So the app replaces, we hope, the paper form of the personal asthma action plan. Here are the questions on the asthma checker. It also asks you to perform a peak flow. So those 10 questions and the peak flow gives us an idea of how patients are managing and how good their control is in the community. And this is something very new. Usually we just get that as a report in clinic or at the GP surgery, but this is real-time data on how patients are managing in the community. And when you've answered those 10 questions, the app will tell you that you could be doing better, or your asthma control is good, or you haven't bothered for 4 years, like the last slide there. Once you do fill in the asthma checker, you can interrogate it, and there are the 10 questions, and you get a green tick if you're doing well, and you get a red cross if you could be doing better. And you can interrogate those red crosses, and it will tell you what you're doing in terms of that modality, how you've been doing, and it's a record of your past inputs as well. So fairly sophisticated. This is for the asthma attack day. How are you feeling? And it's on a scale of 1 to 4, color coded, and it'll tell you exactly what to do depending on how you feel. For healthcare visits and the asthma care bundle and documenting that, there's opportunity to fill that in for wherever you are, whether you're at the GP or your annual review with the nurse, or you're unwell in A&E, or it's a routine clinic in hospital. These can all be filled out to document that the asthma care bundle has been done, and then you have a chance to change the personal asthma action plan and the treatments. So what's the point of the app? Well, there's lots of benefits here. As a patient or a parent, there's an asthma tracker with feedback on asthma control each month. This becomes a way of educating and empowering the patient. It gives you their asthma care plan. We did an audit once in children, and the asthma care plan, which should be on a magnet, a fridge magnet, was not available in almost 100% of patients who attended A&E. They couldn't find it. It gives you an escalation pathway when you're unwell, and there's a lot of videos on there, probably 40 or 50 videos for education. So the patient's being empowered. It gives them an idea and an expectation of what good asthma care looks like, and helps them bring that to the healthcare worker with expectations of quality care. For the healthcare worker, wherever they are, this gives an asthma care plan review. You can make alterations to the asthma care plan and the medication. You can review long-term asthma control from the asthma checker monthly data, and you can document the asthma care bundle when you've completed it. So this has been assessed as being very useful, and funding has been continued for the app and the suite on the education platform, but we need to engage more of the asthma community in using it. So please make sure that at every opportunity when you see somebody with asthma, you engage them in the asthma app, ask them to load it, use it. Otherwise we'll lose it, I'm afraid. This year, register all your patients on the apps. Thank you. Right, I'm going to move on now to the new SIGN guidelines that came out in 2024 for adults and for children. And this has posed quite a few issues for paediatrics, which I think we can go through now. Making a diagnosis of asthma in children is different to making it in adults. But the objective testing that Stein has stipulated has largely come from adult asthma, because there are a larger number of patients with an incorrect diagnosis, and there's a real proper drive to correctly describe COPD or asthma in the community to improve quality of care, save money on expensive therapies. And we need to translate that for paediatrics, who have a different differential diagnosis for wheeze and different diagnostic problems. So for children, not all that is referred to as wheeze is actually wheeze. It's very important when a parent reports that their child is wheezing that you really can identify that this is actually wheeze, because many sounds coming from a chest will be described as wheeze, whether that be a rattle or a stridor or a wheeze. It's very important to try and actually specifically quantify that. So being able to do wheeze, which is an expiratory whistle like this, is extremely important in clinic, asking them to video it, and also looking to see whether it's been documented by other healthcare professionals, perhaps in the emergency room. Not all children with wheeze actually have asthma. That's another thing to think about. There's a wide differential of rarer causes of wheeze, such as aspiration or congenital airway issues that may need addressing. Not all children with wheeze respond to asthma therapies. So when you've got small airways, the three things that happen in asthma are bronchospasm, but also mucosal edema and secretions. And if you've got small airways, the mucosal edema and secretions can cause your airways to whistle even without any bronchospasm, and so salbutamol may not work for these children. The other big issue we've got is that the tests for asthma are difficult in children. They can't be performed in all age groups. They're not available with the expertise needed in all healthcare settings. They're not always reliable in children, and they're difficult to interpret in children. So we really need to model what we're going to do on those NICE guidelines, which are mostly based on adults in children. So we have an All Wales Paediatric Asthma Diagnosis Guideline, and this is available, as I said, on our website. And this looks at, again, making a diagnosis with a positive test. It's a full history and a positive test where possible. So if we go through the asthma likelihood checklist of symptoms, we need recurrent episodic wheeze, recurrent episodic dry cough, diurnal variation, responsive to salbutamol. There are triggers and irritants. There's an atopic history of eczema and allergic rhinitis, and there's a family history of asthma or allergy. These are probably the most pertinent points in the history. What's really important though in children is what's put in the little information box on the left. Important points that cough without wheeze is unlikely to be asthma. Remember, a lot of children get a lot of coughs. They're getting 12 viral infections a year, and they can get a dry cough or a wet cough with those viral infections. Cough without wheeze is unlikely to be asthma. Wet cough is not usually a symptom of asthma. It's bronchitis, persistent bacterial bronchitis. And patients and parents may describe other chest sounds as wheeze, as we've already mentioned. And the last thing is that consider a diagnosis of asthma in children aged greater than 3 with episodic wheeze. So this is the preschool wheeze group, a group which we have been historically very happy to let wheeze and struggle because they are mostly viral induced and not classic atopic asthma. But there will be within that group some children with asthma, with atopic asthma, with treatment-sensitive asthma. And so somebody who's getting episodic wheeze, please, over the age of 3, please do think whether they may need a trial of treatment. We need to consider alternative diagnoses. If symptoms present from birth, maybe congenital. If there's a persistent wet cough, that's not asthma. If there's an inspiratory stridor, that's a different part of the airway. If they're coughing with food and drink to suggest aspiration, or if they're anxious and lightheaded. So here are the investigations that we have stipulated are helpful. But very importantly, not all tests are available to all practitioners, and not all tests are needed to make a diagnosis. So it can be just a clinical diagnosis, but positive test is very useful. So here we have a peak flow diary, skin prick testing, spirometry, and FeNO. And what we've tried to highlight here is where those tests are most appropriately done, how much level of expertise is needed to perform them, and in which age group. So quite a few variables, okay? So peak flow diary can be done from age 5. It's you do it for 1 to 2 weeks. You can document that on the app, and looking for a diurnal variation of 20% supports a diagnosis of asthma. Skin prick testing, allergen-specific IgE, blood eosinophils can be done from age 3 onwards. In the context of having a wheezy illness, is very supportive of a diagnosis of atopic asthma, increases the probability, but there are people who do have atopic disease without asthma, so it's not an absolute test. Spirometry with reversibility testing can be done successfully in children over 12 in any environment without extended expertise, but in children under 12 probably needs a specialist skill set and should be reserved for respiratory clinics. And FeNO similarly is easy in patients over 12, but in under 12 can be difficult to interpret, because if you do it with a viral infection, your inflammation is neutrophilic, and if you do it when you don't have a viral infection, your inflammation may be eosinophilic. So there's variability with time, and given that children have so many colds, it's very difficult to interpret. So once you've done the tests that you can do in your healthcare environment and in the specific age of your patient, you may come out with a strong clinical impression and a positive result, a strong clinical impression without a positive test result, or no evidence at all. And moving on, you can either diagnose asthma with the positive test result, suspect it, in which case you may watch and wait, or you may give them a treatment trial, or you may have a low probability of asthma and asthma can't explain those symptoms. You need to look at an alternative diagnosis, repeat those tests, or refer up. And then if you do start treatment, you really need to follow up, review 6 monthly if asthma is well controlled, or 3 monthly if poorly controlled, and after each change to medication. So here's what we do, and I will compare that to what NICE suggests in a moment. There's a long diagnosis guideline supporting notes document to help you use it. We move on to the management of asthma. We've got supporting notes and a national standardized, safer and sustainable approach to asthma care, which I've mentioned is explicit in referral thresholds and national medication choices. And this is what it looks like. And I hope you're familiar with it because it's been out for a few years. It divides patients to those under age 6, between 6 and 11 and 12 years and over. Now, I've already mentioned that the age 12 years and over can do all of the objective tests that adults can, and we've tried to align their care, their management and their medication choices, align them to the adult medication choices. The licenses for the medications also usually start at 12, so it seems natural that they are managed in a similar way, and I'll go through it in more detail. So what are the principles we've got here? There are 3 age groups. Age over 12 can be managed like adults, both in their objective testing and in their treatment choices. For spacers, please use the Aerochamber Plus series. We've made this a national choice. Pharmacists, I think, everywhere now only stock those, which is excellent. Remember that MDIs with a mask are a compromise. A mouthpiece is so much better. But children under 3 can't really reliably use a mouthpiece. Those over 3, however, should be changed to a mouthpiece spacer immediately. And there's no evidence that it can't be used in that age group, both when well and unwell. So they don't need 2 spacers. They don't need one with a mask and one with a mouthpiece. Just a mouthpiece will suffice. So in this management group, we tried to place dry powder inhalers in children. Obviously, there's a technique to that, but they are licensed from over 6 years of age, and there's a lot of evidence that they can use it successfully. I'll show you a video a bit later of a 6-year-old using a DPI. And so we've really tried to move things to consider to switch from 6 for dry powder inhalers. There's an environmental cost also to MDIs. So switching from 6 as part of our protocol has been established now for some years. We've also been keen to get children of this age and to get practitioners confident in prescribing dry powder in this age, because we knew that MART therapy would be coming to this age group, which it has done now. But there is a very important element to this. There needs to be adequate time for technique training here. Other principles that we've used is we wanted to stick to national prescribing choices so that we don't have a bag full of different inhalers, prescribed by brand so that we have consistent delivery. And we also, of course, use an ICS and a long-acting beta agonist always in combination inhaler, no green inhalers anymore. And we've also prescribed a SABA and MDI in space for emergency use in all children, even if they're on MART therapy. And I'll come to that later. So here we are. Here's the 3 different age groups. And if I go through each individually, just to recap, for age under 6 years, the first stage is low dose Clenil and a short-acting beta agonist. Then there's a trial of Montelukast, although that may not stay in the guideline for too long, because it does have, there's more and more evidence that it does have psychotropic side effects. I think if you haven't got your under 6-year-old under control in primary care with those treatments, then you should refer to secondary care. For the age 6 to 11s, in the existing guideline, again, we start with low dose inhaled corticosteroids plus a SABA with an option for dry powder or MDI. Dry powder is preferred, switch from 6 if you can. A trial of Montelukast, but only for 6 weeks, stop it if it doesn't work. And then we've gone to a low dose ICS LABA combination as the next step. So there's no place for moderate dose inhaled corticosteroids without a LABA. So Flixotide, not really in our protocol at all. You move from Clenil low dose pediatric low dose ICS to pediatric low dose ICS LABA with Symbicort 106 or the equivalent Serotype. And if you haven't got control in primary care at that stage, you refer to secondary care. And in our current guidelines, we do not have MART therapy age 6 to 11, but I will come to that. Age 12 and over, we've been quite ambitious, I think, for what primary care can do. And again, we were trying to align to what is done for adults. Again, we start with adult low dose inhaled corticosteroids for this age group. And a SABA, trial of a Montelukast, and then we change to adult low dose ICS LABA, but here it's either fixed dose or it's a MART regime, and that fixed dose is Symbicort 106 or Relvarilipta 9222, and the MART regime is low dose Symbicort MART. So those are quite ambitious steps for a young teenager to be managed in primary care. It's always difficult to define referral thresholds. There's a large difference in expertise in primary care with regard to managing asthma in children. Some people will feel very confident to go further than the referral threshold. Others will be less confident. This is where we've placed it. Okay, so these are the current primary care thresholds. So for under 6s, if you haven't got control with Clenil 100, 1 puff twice a day, and Montelukast, send them to secondary care. In the 6 to 11s, if you haven't got good control with Symbicort 100/6 1 dose twice a day with Montelukast, send them to secondary care. And age over 12s, if you're not well controlled on low-dose MART therapy or relvaroliptal with montelukast, send to secondary care. So quite high thresholds from primary care, quite ambitious, but we're definitely seeing something work very nicely here with our referrals into the hospital clinic. Okay, so what about the NICE guidelines and how did this change things? Well, the emphasis is definitely on objective tests for diagnosing asthma and a universal introduction of AIR and MART therapy in age over 12 years. And I'll go through that. And then most contentious is the introduction of MART therapy in age 6 to 11 years, which needs a little bit of thought. So just going back to tests for asthma, cannot be performed by all age groups, not available in all healthcare settings, not always reliable in children, and difficult to interpret in children. So with that in mind, here we have the NICE diagnosis guideline for objective testing in 5 to 16-year-olds. And I'd like to say that that is a very broad age group. What you can do in a 6-year-old and what you can do in a 16-year-old is completely different. Okay, so this guideline looks at FeNO, spirometry, peak expiratory flow variability, which is the peak flow diary, and skin prick testing. Okay, now it accepts that FeNO and spirometry may not be available, and it expects one positive test is adequate to make a diagnosis. Now that age range is very broad, and we've already talked about the fact that we may not have testing in all young children in all healthcare settings. We may not have a positive test, in which case a trial of treatment may help us. Now, this guideline is not specific about which tests are available in which healthcare setting, so it is expecting some local interpretation, and I think that's what we're trying to do with our Wales guidelines. So if we compare what I showed you about what investigations we do versus theirs, I was pretty happy to see that they've chosen the same 4 things as we have. And so we've got a consistent interpretation and a more practical interpretation because we're taking into account which healthcare setting and which age group can do which of those tests. We want one positive test also, but we stratify testing to age 6 to 11 and age greater than 12, which I think is helpful for practitioners. And we're also considering which healthcare settings have the expertise and the resources to do which tests. So I think we're consistent with what NICE are asking, and I think that diagnostic algorithm that we have still stands. It does mean basically that for under 12s in primary care, you don't need to do FeNO and you don't need to do spirometry. You stick with either history alone in the very young, a peak flow diary, and possibly skin prick testing and blood tests. Right, I'm going to move on to the treatment pathway for children over 12 years of age, which highlights AIR and MART therapy. So AIR stands for anti-inflammatory reliever therapy. And to explain this, I need to explain MART therapy first. So MART therapy is maintenance and reliever therapy with a single inhaler which contains inhaled corticosteroids and a rapid onset long-acting beta agonist formoterol. And this is given as morning and night maintenance therapies and additional puffs for reliever therapy. This means that if you have uncontrolled asthma, you take more reliever therapy, but with that reliever therapy, you get an additional dose of inhaled corticosteroid, and therefore you are auto-titrating how much steroid you get against how many symptoms you have. And that's the magic of MART therapy. Now, AIR therapy is similar, except you don't take any maintenance therapy in the morning and at night, and you just carry that combined ICS rapid onset long-acting beta agonist inhaler, which is Symbicort really. You carry that with you and you use that for relief only. That means that if you don't get any breakthrough symptoms, you don't get any steroid. And if you do have breakthrough symptoms, you auto-titrate up on a steroid dose. And that means you'll be getting less steroid in all. Now, the big advantage of this is it prevents excessive short-acting beta agonist use. So no salbutamol in the equation at all, but it also ensures that inhaled corticosteroids are taken in symptomatic patients using their reliever. So what's happening at the moment is that patients who are on twice daily Symbicort plus salbutamol reliever inhaler is that they're probably not taking their twice daily maintenance therapy and then relying on salbutamol for reliever. So this ensures that an inhaled corticosteroid is taken in symptomatic patients. So the NICE guidelines suggest that every new asthmatic over the age of 12 now starts on air therapy as their first step. And I'll go through that in how we might change our management plan. The step after that will be low dose MART therapy. After that, moderate dose MART therapy. And after that, some more esoteric additions that would happen in secondary and tertiary care. So that very much simplifies the pathway for children over 12 years of age. It's completely concordant with the adult services and is something that we are going to implement here. So here is age 12 years and over, the pathway as it exists at the moment. It does have MART therapy in there, but what's going to happen is the primary pathway is now going to be air instead of Clenil and SABA, low dose MART and a leukotriene antagonist, then referral to secondary care for moderate dose MART and a leukotriene, and then referral to specialist clinics for anything else that's needed, including potentially biologicals. So simplifying. Now, if people are well controlled and already on asthmatic therapy, they don't need to transition to the primary pathway. So there will still be this alternative pathway, which will look similar to what we have already, except there won't be any MART therapy alternatives in that. This is the fixed dose ICS, LABA and SABA pathway. So there is going to be a change for all 12-year-olds. They're going to go on air and then follow low dose to moderate dose MART therapy. There are many different ICS, LABA alternatives now available. We will limit those choices to prevent unwarranted variation and suggest perhaps that we just use Symbicort as our only DPI in this group. Here is the alternative pathway on the left and the air MART therapy on the right. It's extremely complicated, so we'll have to do some local interpretation to make that look clearer, but there will still be two pathways. Okay, what about introduction of MART therapy in age 6 to 11-year-olds? So it wasn't licensed up until a few days ago, but now has been licensed. Symbicort was licensed before in this age group, but not for MART therapy. It's now been licensed, but there still exists little evidence for safety in this age group. And it's a vulnerable age group who still getting frequent viral exacerbations, so many more exacerbations than older children and adults. Also, they're looked after in multiple spaces by many different responsible adults, whether that be school, football, clubs, babysitters, other sports teams, places where they may get symptoms and require reliever therapy. And there's a conceptual change in how we're going to give reliever therapy to this group, what rescue treatment they need, what personal asthma action plans say to do when they're sick. There's a lack of familiarity at the moment in healthcare professionals for this age group, including school nurses, and there are a few licensed medications to choose from. So it does raise age-specific difficulties, which we don't have in the over 12s, which we don't have in the adults, but this group, it's difficult. What real-world problems might we see, even if the license trials didn't show it? Well, this introduces multiple variables for thousands of carers, okay, all across every health location. People are managing children with asthma in school and in all those clubs, in GP surgeries, in nurse clinics, in hospitals. And there will be two pathways. There will be the MART pathway and the alternative pathway. Some people will be getting SABA for relief, others will be getting ICS LABA for relief. How do we know who can use a dry powder inhaler when they're unwell versus who can't? Who gets what before exercise? Are we going to give steroids in asymptomatic children before exercise just in case? They may be getting that 3 or 4 times a week. and which personal asthma action plan applies to which child, for example, in school. So lots of real world problems we have to try and think about. And there are potential issues as well. The psychological dependency on short-acting beta agonists for every feeling of breathlessness always results in the giving of salbutamol away from the parents. That's the safest thing to do for the school nurse, for the football team, for anybody looking after that child. That psychological dependence will still exist, but we'll be swapping overuse of SABA for overuse of ICS-LABA. So are we going to get adrenal suppression? We're going to get a group of Cushingoid children? Who knows? What about safety with exacerbations? The MART regime precludes prescription of a SABA for emergency relief. Now that might be appropriate in responsible adults, even in responsible adolescents, but is it appropriate in this age group who get unwell much more frequently and much quicker? Do we take away their SABA and spacer completely, or do they still have this as well as their MART therapy? So this has been addressed by the British Paediatric Respiratory Society. There's some consensus recommendations on how to implement MART therapy in this age group. So there needs to be a few, according to this expert group, there needs to be some infrastructure in place for this. So the healthcare professional explaining, prescribing and implementing MART needs to be trained to tier 3 level on National Capability Framework for professionals who care for children with young people with asthma, so a specialised nurse. There needs to be more time for checking technique on dry powder devices and for understanding how to use that regime. And there needs to be more infrastructure for closer monitoring and regular surveillance versus conventional therapy. So quite a few caveats to starting this treatment. So here's age 6 to 11 years as we now have it. Remember, we have been quite ambitious in this age group, switched from 6, dry powder inhalers from 6 years of age. So we're well positioned to implement MART therapy in this age group. But I think what we're going to do, at least in the first instance, is introduce it in secondary care rather than primary care, where all of those caveats that I've just outlined are easier to implement. And then when we've got confidence, we can change and potentially start this in primary care. So a two-step approach. I promised I'd show you a 6-year-old a 6-year-old with perfect technique on a dry powder inhaler. It is definitely possible. So the next problem is that MART precludes the prescription of a SABA, salbutamol or equivalent for emergency relief. Is this appropriate for this age group? So we have to come up with some sort of local interpretation of this. And I've spoken to a lot of people in England about this. And I think for over 12 years of age on air or MART therapy, we would prescribe SABA plus a spacer to children commencing air and MART therapy. Keep it in the cupboard for asthma attacks. It's not for everyday relief of symptoms. There is a discretion to withdraw the SABA at 6 months once established on air, MART and stable, but there will be some people that will need SABA prescribed long term. And different areas in England are using different criteria for this. If you've been to hospital, if you've had an asthma attack, if you've had steroids, maybe you need a SABA until you gain complete stability without it. Age 6 to 11, I think we prescribe SABA plus spacer to all children age 6 to 11 years for emergency use on MART therapy or on fixed dose. Again, keep it in the cupboard for asthma attacks. It's not for everyday relief of symptoms. You know, I'm doing this already on MART therapy in this age group. And the fear is that if they've got a blue inhaler in the house, they're going to be dependent on it. I've not seen this happen at all. It's been transformational for this group and for the 12 and overs. They're using their Symbicort MART therapy and hardly ever using the blue inhaler. So they can have it, but good instruction that it's not for everyday relief of symptoms. That's your MART therapy. And I think maybe there could be discretion to withdraw a SABA in the older age group here from 8 to 12 years if they reach stability. But for the younger ones, I think still they will need a SABA for the asthma attack day. So what about school nurses? School nurses, I think, are very, very important in this equation. There's an increase in complexity in managing symptoms at school. Who's going to be getting MART? Who's going to be getting SABA? We need to generate some specific guidance for school nurses with regard to MART and conventional pathways for symptom relief at school. Okay, I'm going to stop there. I've talked about what the problem is and how we're doing. I've talked about asthma apps and National Educational Platform, our existing guidelines and the new NICE guidelines. Thank you very much.
Thank you very much, Professor Forton, for an informative presentation. We're running a little bit behind.
Yes, I'm sorry about that.
As we're due to finish at 15:15. So I'm wondering if people would like to stay for a couple of minutes so that we can answer 1 or 2 questions, and we'll put the rest in the Q&A. So we have a few questions in the chat.
Yeah, okay. Do you want me to go through those? Let me go from the top.
Yeah, see what we can address now, and maybe if there's anything that requires more time, we can do a Q&A.
Okay, Leanne Lewis Davis is right. So for schools, will they not have access to care plan for a pupil as they normally have paper care plans? So this is a question about the electronic care plans on the app. So the app has a function to download a PDF. So that PDF can be shared with the school nurse. And I've just mentioned at the end also, the school nurses do need support here, and we will be developing some guidelines specifically for school nurses with regard to MART therapy. But you should be able to get the plan as a PDF emailed to you by the parents of your children. Ruth Knox asks, are we able to link into the patient's app and amend details while they are in a consultation with us? Yes, you are. This is the design of it. But the app is owned by the patient. It's on their phone. They need to bring their phone, share that with you, and then you have an option to go into consultation, to go through your asthma care bundle, all the things you need to ask, all the things you need to do, and then have an opportunity to update if you change the medication. Absolutely. Jackie Reynolds has asked, Symbicort MART now licensed from 6 years. Are there plans to update the guidelines to be more in line with NICE BTS now that there is a licensed product? Yes, there are. I think we've gone through that since you put that one in. With respect to air therapy, only the Symbicort 206 has a license to be used in air regime. That's okay for age 12 and over. We're not going to start air regime in 6 to 11, so that dose is okay. Marcia, hi Marcia, what about children using salbutamol prior to exercise for exercise-induced asthma? Exactly. So this is a problem because if they're using it 5, 6, 7 times a week, they're going to get steroid piggybacked on when they don't need it because they've got no symptoms. So this is a difficult problem to address, and I've talked to people across the UK about this. And I think what we're going to do is include that in the school nurse guidance. And I think if people are using it more than 3 times a week preschool, then they should start to use a salbutamol inhaler for preventative use and just stick with the Symbicort for reliever use. It's a difficult one, that one. Should we be giving children currently on step 1 asthma guidelines and a DPI, MDI with spacer also for asthma attack? I think we've talked about that. And the answer is yes, all children at the moment in Wales, even if they're on a DPI, should be having an MDI with spacer in the cupboard for an asthma attack. What about air therapy for an 11-year, 5-month-old? Bethan asks that. That's up to you. It's fine by me, but yes, that's up to you. I don't think you have to wait till 12. Sometimes I use it off license. It was an off license treatment then, but no reason why you can't use it. Jackie
Thank
Reynolds.
you.
Mark plus SABA in children, the key will be not to add to repeat in primary care, only issue as acute. So use can be monitored to prevent over-reliance. Absolutely. So we really have to be careful with those SABA. That's why there needs to be a review of stability and then potentially taking it off the repeat prescription. Within a hospital setting, how should we wean a patient from nebulized IV therapy to MART therapy? Yes, so this is another issue that we're going to need to, if you look at our asthma care plans, they do have a weaning strategy after an acute exacerbation, and that will need to be changed. So Asthma and Lung UK do have a weaning strategy, weaning from salbutamol to MART therapy on discharge. So you would set them up back on their MART therapy before discharge. That will all come in the paperwork. By not considering FeNO and BDR in under 12s group, we limit the number of objective tests available, as many practices will not be able to undertake paediatric bloods routinely. This only leaves us with peak flow diary monitoring. That's correct. Unfortunately, that's correct. But the trouble is with FeNO and BDR is that they are very difficult to interpret, very difficult to achieve accurate results. And if you don't do it correctly, then you get a disease phenotype. So that's the difficulty. And we've had to be very, this has involved a lot of thought, but we don't think we have the infrastructure to say, generate expertise in every healthcare setting for those tests. Do you have any?
Julian. I think we'll maybe put the rest of the questions in the Q&A. I'm just mindful of the time and some people have to leave.
Okay, yeah.
So that was really, really informative. Thank you so much. Before we finish, I just wanted to thank you for your time and a great update on asthma care in children. And I would like to thank each one of the attendees today for your time to join. So we will have a recording available within a couple of days on our website. We will also upload it onto the Respiratory Matters SharePoint site, and the link is in the chat. Nick posted it at the beginning of the webinar, so you can access all the recordings there as well. We issue certificates of attendance to support your CPD, and if you would like one, please email the network and we will be happy to provide you with it. And if you found the session useful, please share the recording with your colleagues. We hold these lunchtime webinars monthly on a variety of different topics. So far, we have covered the respiratory data dashboard, the Green Agenda and inhaler use in Wales, and the National Respiratory Audit Programme. So if any of these topics are of interest, you can find them on our website or the SharePoint site. And the next date for the calendar is Wednesday, 15th of October, same time, 12:30. And Francis Barrett, who is a primary care respiratory trainer, will join us to talk about implementing the new asthma guideline that Julian touched upon today. I think there'll be also more of a focus on the adults in that talk. And more details and the registration link will be shared shortly. And if you're interested, make sure that you're on our mailing list. So thank you all for joining, and we wish you a good rest of the afternoon. Thank you very much, everyone. Thank you, Julian.
Thank you.
Thanks, Julian.